Hey everybody, welcome back to the 30-day EKG challenge. My name is Reed, and we've got a similar story to this EKG as yesterday in terms of the myocardial infarction, but I want to talk to you about how to make sure that you don't miss other findings on the EKG at the same time. So this is going to be a fun one. So the first thing I'm going to do is not zoom in on the obvious, right? Sometimes you can look at these and you can be like, I can see the ST segment changes to myocardial infarction. Let's move on. But if you look closely, as I scan through this rhythm, this is why I like to go anatomically through the EKGs, I notice that I've got a narrow complex rhythm. Remember, my QRS complexes are narrow. So my QRS is less than 120 milliseconds, or 3 small boxes. And that tells me that my QRS complex, right, is coming at least from my AV node down the His-Purkinje system. But if I look at the rhythm itself, it seems to be quite irregular, right? There's some shorter ones, some longer ones, short, long again. So it's kind of all over the place. And when I look for atrial activity in front of these QRS complexes, I don't see any distinct atrial activity. And so notice that in the setting of no distinct atrial activity, in fact, maybe some baseline kind of signal within the atria, and in a rhythm that is quite irregular, but still narrow complex, that tells me that this is probably atrial fibrillation. So we've identified that this is atrial fibrillation. Remember, atrial fibrillation is an atrial arrhythmia. It can happen and coexist with STEMI, where you have these fibrillatory waves kind of within the atria, and they're bombarding the AV node, and the AV node is a bystander, right? It's just getting hit with all these fibrillatory waves, and so it randomly conducts signals, right? It doesn't do it in a regular fashion. It does it in an irregularly irregular fashion, and when it does that, that creates our rhythm being irregularly irregular, and our QRS complex needs to be evaluated independently of the AFib, right? So I've identified AFib. Let's identify what the rate is for the AFib. I know this is a 10-second strip, and so the way I like to do my rates for AFib is if this is a 10-second strip, if I count the number of QRSs in this 10-second strip and multiply it by 6, I should get the rate. So let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So 17 beats times 6. Man, making me do math again. 6 times 7 is 42 times, or plus 60. So I think this is 102 beats per minute. So we've got an atrial fibrillation with just a mildly rapid ventricular response, right? Rapid ventricular response is anything over 100 beats per minute. So that tells us a little bit about what's going on within the atria and how the AV node is behaving. The next thing I'm going to do is evaluate my QRS, right? Because that's the next phase of our cycle is ventricular depolarization. We said that our QRS was narrow. When I looked at my QRS axis, my QRS is, notice, upright in lead 1, so it's headed to the left towards V1, but it's negative in AVF. So that tells me that we're getting some leftward changes of our axis. It's kind of heading up and to the left, which is not typical. And if I look now, I'm like, well, why is my QRS axis kind of going up and to the left? That doesn't make sense. Well, I notice that I've got these these initial deflections in the QRS complex that are very negatively deflected in my inferior leads. And so you'll notice too that my inferior leads here, specifically lead 3, has some serious ST segment elevation. AVF has a little bit less, and then just some changes here in lead 2 as well. So we've certainly got inferior ST segment elevation. We've got those reciprocal ST segment depressions in lead 1 that help verify that these inferior changes are correct. And if you look really closely in V2, I've got some ST segment depression. Here's my baseline. Here's my ST segment depression. So I've got some posterior changes. If you're just tuning in, I talked a little bit about this in yesterday's video. So I've got inferior predominant myocardial infarction plus some posterior extension. And how does that explain the left axis? Right? So if our QRS is shifted to the left, Why? Well, imagine if my inferior aspect of the myocardium right here is ischemic slash infarcting. Well, the signal is not going to travel that way really well. It's going to have to travel this way. So you get a shift in your QRS axis away from that region. And how can I know? What is a sign that tells me that this region, this inferior region of myocardium, is there a sign that can tell me that maybe it's not conducting tissue so well? Absolutely. Here we have something called pathological Q waves. So we have something called pathological Q waves. And those Q waves, look, notice that my QRS complex here in lead 3 is just a negative deep Q wave. Look at lead 2. It's just a negative deep Q wave. Look at lead AVF. It's just a negative deep Q wave. Those are all pathological Q waves. And that tells me that there is no measurable amount of signal that are heading towards these leads because they're dying. That myocardium is dying. And that's what pathological Q waves tells me, that there is a serious dysfunction within that region. And so this myocardial infarction is likely quite progressed, right? So we have active ischemia as demonstrated by our ST segment elevations here. But those pathological Q waves tell me that there's already been a considerable amount of damage from this process to the myocardium. And so that really helps explain our QRS axis and some of these changes. So the whole point of this video was for me to talk to you about how to anatomically break down different findings on the EKG, right? So the first thing we did is we determined what is the rhythm and how does that correlate anatomically. We have an irregular rhythm that is consistent with AFib, and we know that AFib is an arrhythmia arising from within the atria, right? We also know that the ventricular response, which in this case was 102 beats per minute, that's a function of the AV node, which sits right here. And then we know that the QRS complex and those ST segment changes are indicative of what happens inferiorly from my AV node sending signal down. So breaking it down anatomically will help you identify the significance of all these changes and what that means in the clinical setting, so that when you treat your patients, you know what aspect of their anatomy that you're treating. So I hope this helps. If you have any questions about this EKG, feel free to reach out. And if not, kind of crazy that we're on day 25 of the challenge. I'm super excited for what's to come, and see you on the next EKG video. Have a good rest of your day.